Good afternoon, everyone. How are we all doing this afternoon? Great. Happy Friday. I am very excited that it's Friday. I've had a long week. I'm assuming maybe some of you have the same experience as I. But my name again is Yareni Sime, or Sime correctly. But I work for the Partnership for Maternal Child Health of Northern New Jersey, and we service the northern 8 counties. And a little bit about myself, just so you guys can get to know me. My academic background is in public health. I received my undergraduate degree from the University of Rochester in both public health and psychology, and then my master's in public health from Millman School of Public Health at Columbia University. Yes, and since then, I have been doing maternal and child health work, but that also includes reproductive health work. And so when I started at the partnership in 2021, I was exclusively doing HPV education to communities, to students in high schools, middle schools, and to healthcare professionals. Since December of this past year, I have moved on to another role at the partnership where I am now the manager of doula training programs. So I educate other community members to become community-based doulas. But I don't forget any of the information that I used to present on. So I still present here and there on HPV, but we do have another person that is fulfilling that role on educating on HPV and other immunizations under our immunizations department at the partnership. So I will provide my information at the end, but if anyone wants to reach out to me, they can to then connect with the immunizations department at the partnership. And also, I like to share that I'm a native New Yorker. Yes, born and raised in New York City, but I do all of my work in Jersey, well, most of my work in Jersey. So yeah, so thank you so much, and thank you for that warm welcome. So today's presentation is HPV vaccine is cancer prevention. This is a healthcare professional's guide to speaking to families about HPV. Are we all familiar here with HPV, how it's transmitted, the vaccine? I'm still gonna go a little bit into it because not everyone gave me a head nod, so I'm gonna just do a little bit of background. But please, I apologize if this is a little redundant, but I do want to share because I know that there are healthcare professionals that don't necessarily engage in HPV education, don't really know, and can gain something from understanding a little bit more about HPV itself. So first and foremost, I want to share disclosures because we got to share disclosures. So neither the speaker nor the planners have any conflicts to disclose. And funding for this initiative has been provided through a grant to the Partnership for Maternal and Child Health of Northern New Jersey from the White Health Foundation. The prevalence of HPV-related cancers. 2, identify ways to recommend the HPV vaccine to families. And 3, discuss the healthcare professional's role in HPV cancer prevention. So a little bit of background. HPV is the most common sexually transmitted infection. Many people can believe that it can be, gonorrhea or chlamydia, but this is actually the most common one in the world. So 90% of the population at some point in their life will be exposed to HPV in some capacity. Now, that's not meant to, worry anyone or scare anyone, but it is that common, and I'm going to talk a little bit more about that. So approximately 79 million people in the United States are infected with HPV, making it the most common as sexually transmitted infection. It's so common that 8 out of 10 individuals, again, will be exposed to HPV at some point in their lives. There are over 150 HPV strains, and some of them are high-risk strains that cause cancers, and some of them are low-risk strains that cause warts. And they can be on surfaces such as the hands, the feet, and the genital area. So how is it spread? We know that it is spread through intimate skin-to-skin contact and by having sex, including vaginal or anal and oral sex with someone who has the virus. And this can be transmitted even though there are no signs and symptoms. So because it is categorized as high risk and low risk, the low risk HPVs do not generally cause cancer, and as I mentioned, genital warts. But then the high risk that cause cancers are the most common strains are HPV 16 and HPV 18, which are responsible for most cervical and oropharyngeal cancers. Before I move on to the next slide, in most cases, so for the majority of us, 9 out of 10 HPV cases will go away on its own without causing any health problems. So when I say, the majority of the population can at some point transmit HPV, also the majority of the population can also fight off the infection on its own. So it's like a common cold where it's in our system, we fight it off, and in a year or two, we're tested for it and it's no longer present in the system. So that's something that I, like to share, especially with my students, because when I used to educate my high schoolers, I would say almost everyone in this room, with the exception of one or two people, at some point in their life will be exposed to HPV, and they would all, be terrified. And I would say, wait, that's meant to let you know just how prevalent it is, but it's also important to know that the majority of us will fight off the infection. And unfortunately, for those of us where it lingers in our body, it then progresses to precancers and later on full-on cancer if it's not caught in time. So I like to share this graph because this graphic shows the numbers of individuals diagnosed with HPV-related cancers. So per year, 14,000 individuals are diagnosed with oropharyngeal cancer. This actually surpasses the number of individuals diagnosed per year for cervical cancer, which is about 11,000. Sometimes the number fluctuates per year, but generally this is what the numbers look like. Oropharyngeal cancer is now the most diagnosed type of HPV-related cancer, and oropharyngeal cancer is most prevalent in men. So about 70% of oropharyngeal cancer cases are in men. Cervical cancer is the only type of HPV-related cancer that has a recommended screening tool for early detection. And what does that mean? That means that, for oropharyngeal cancer or for other types of cancer, there are no screening detection, right? So a person can come into their dentist, and the way that a doctor will be able to tell that that person has cancer is because there are warts and lesions in the mouth, which will then be diagnosed as oropharyngeal cancer. But in terms of cervical cancer, we can screen for that. And even with screening methods to detect cervical cancer using tools such as pap smears, about 4,000 women die each year of cervical cancer. And even though I share this number all the time, it really blows my mind to know that in 99% of cervical cancer cases, it was caused by an HPV infection, making it extremely, extremely preventable. And so when we hear of a cervical cancer case, we can in almost all cases say this was because of a preventable HPV infection. It kind of hits differently when we know that there are things that we can and cannot prevent, but this is something that is absolutely preventable, and we can protect everyone that has a vagina, right? All of those who are born with one and can protect themselves with the vaccine, which we'll get into. And so that's why we see that little iceberg, because there's no screening for most cancers. So that's the tip of the iceberg, showing how everything else below it, there's really no screening detection until once the person is diagnosed. And now we have to deal with cancer treatment and making sure that we're limiting the expansion of the cancers. But yeah, cervical precancer numbers extremely high. Let me move on to the next graph, because this one actually shows like a visual of the numbers in terms of the HPV-related cancers in the United States each year by sex. So as you can see, oropharyngeal cancer cases in men, 11, almost 12,000 cases in men, and in women it's about 2,200. Cervical cancer cases in women, 11,000. Anal cancer, almost 5,000 in total between men and women. Vulvar cancer, 2,800. Penile cancer, about 900 to 1,000 cases in men. Vaginal cancer, about 700 cases in men. Did I say 9,000? 900 penile cases, and 700 vaginal cases, making a total of 21,000 approximately in women and 14,000 approximately in men. So yes, and this includes teenagers as well, right? Like this includes the youth. Even teen girls are being diagnosed with cervical precancers, and so they are not immune to this disease. And so it's pretty important to discuss as to our are young boys and girls. And from you can see here, cervical cancer is the most commonly diagnosed in women, and oropharyngeal is the most commonly diagnosed in men. So what makes HPV different from other STIs is that it shows, for the majority of the time, no symptoms whatsoever. And so people can continue to spread HPV because many of them don't even know that they have it themselves. They can expose others because there are no symptoms that show in the body, right? The only way that someone can see a physical symptom of HPV is if they have one of the low risk strains that can cause genital warts or other warts, and you can physically see that. But for the most part, this one, HPV, is very different because we know that with other STIs, people can see symptoms of vaginal odor, vaginal discharge, itchiness, irritation, discomfort, which none of these are present with HPV infections. And so that's why a lot of people don't know that they have it, and then continue to spread it to others. And we love to educate on making sure that that people are protecting themselves as best they can, using barrier methods such as condoms, especially our teenagers, making sure that they're informed about protecting themselves and having safe sex and receiving the proper and correct study science-based information. Vaccinating teenagers and anyone is a cancer prevention tool because it can prevent over 90% of cases. And we want to discuss the HPV vaccine as a cancer prevention tool. So it was first introduced in 2006, and since then, over 150 million doses have been administered worldwide. A lot of people are concerned about its safety and efficacy. We know that it is a safe and effective vaccine. Many trials and studies have been done prior to the release of this vaccine. It was first given only to girls because we thought that HPV was just a girl problem. And now we know that men are impacted by HPV and they can get penile, anal, and oropharyngeal cancer. So we're giving the same recommendations to both boys and girls. And so it is recommended from anyone between the ages of 9 and 45 years of age. It was originally provided or administered up until the age of 26. But more studies have shown that even past the age of 26, even past the age of sexual initiation, even after having children, it still provides a benefit to protecting ourselves from HPV infection. Because, and a lot of my teens ask me, it's like, so what if I'm already exposed to HPV? Should I get vaccinated? And I say, absolutely, because again, there are over 150 strains of HPV. And let's say we're exposed to, I don't know, strain 6. We can protect ourselves from 8 other strains, right? Because the vaccine protects against currently 9 different strains. We recommend that it is provided to everyone from ages 9 to 45. Widely, and including even the CDC, recommend that it is given between the ages of 11 through 12 to initiate. But now we are actually moving that down even further and encouraging providers to vaccinate at age 9, because we have seen that at early as 9 we can protect children. And we also recommend to parents to have their children vaccinated for HPV as early as 9. And we're going to talk about why we give this recommendation, but just to quickly share that it's usually given at 11 or 12, right? Because we are vaccinating with Tdap, we're vaccinating with meningococcal for school. But when we do that, which is obviously a great technique, it becomes, when children become a little older, it becomes more of a sex conversation. If parents are asking, wait, hold on, I know that I'm protecting my kid from meningococcal. I know that I'm protecting my kid from Tdap, but why do I need to protect my kid from HPV? They're not sexually active yet, right? And so by initiating the vaccine as early as 9, it's not a conversation about sex as much as it is about cancer prevention. And all of this is about the messaging, right? So the American Cancer Society and the American Academy of Pediatrics strongly recommend receiving the first dose of the vaccine within the ages of 9 to 11. This is because adolescents at this age have a greater immune response to the vaccine. the dosage of the vaccine is dependent of the age of initiation. So the way that it is done is that a child will receive their first dose. If they're between the ages of 9 to 14, they will receive their first dose. They'll come back 6 to 12 months later, receive their second dose, and then they're done for life. If the child is over 15 years old, and that is when they start to receive their very first dose of the HPV vaccine, then they would receive their first dose, come back, get 6 to 12 months later, get their second dose, come back 6 to 12 months later, get their third dose, and then they're done. This is the same case for anyone over 15. So if you're an adult and you're starting your vaccine series, you would receive 3 doses. But if you're under 14, when you first initiate, then you would only need 2. Concerns about the HPV vaccine are the possible side effects. And they include very similar side effects than any other vaccine that we've ever received. Pain or redness in the injection site, fever, dizziness or fainting, which tends to happen more amongst our younger population, our teenagers, nausea, headache, muscle or joint pain. And so these are the things that, parents really are, what kind of side effects does this vaccine have? I don't feel like this is safe. But again, it has been tested and tried, and we know that this is safe and effective. The HPV vaccine is one of 2 vaccines in the world that prevent against cancers. And the only other vaccine is the hepatitis B vaccine, which protects against liver cancer. But if there is a vaccine out there that can protect my child from HPV, I'm most certainly going to want to protect my kid, right? And so this is the dosage and the side effects of this vaccine. So again, they're common side effects from the vaccine. They're mild and they resolve within a day or 2. Oh, actually, one other thing that I want to share about vaccinating kids at 9, right? So the HPV vaccine is most effective when given before an individual is exposed to the virus. For that reason, right, that if we vaccinate earlier on before they become sexually active, then we're protecting them from all of the strains that the vaccine can cover, right? So we're protecting them against 9 different strains. And so we want to make sure that we're getting it as early as possible, right? Because we don't like the idea of our kids at some point becoming teenagers and becoming adults and becoming sexually active. But realistically, they will, right? And so we want to make sure that they're protected prior to any kind of initiation of sexual activity. And so once they become sexually active, then we have done our due diligence to protect our kids. So this graph here, and now I'm getting a little bit more into the New Jersey HPV vaccine coverage rates. So this graph here shows the national and state data collected by the CDC's annual National Immunization Survey, the NIST. This graph illustrates the vaccination rate of HPV from years 2018 to 2023, and it shows the up to date and the United States up to date, right? So we have a Healthy People 2030 target of 80% vaccination across the country. We didn't hit it in 2020, and we're on track, but we're still working on trying to hit it for 2030. But the way that it's looking, especially in New Jersey, it's not looking so good. So as you can see, the US is that yellow line, and then the New Jersey up to date is that orange line. And you can see from 22 to 23, it has actually decreased. So while we want to see an increase, right, we saw a little bit of a decrease during the pandemic, which makes sense, right? People were home, people weren't getting their vaccines, people weren't going to, kids weren't going to school, so they weren't being vaccinated for anything. But it rose a little from 21 to 22 when kids are starting to go back into these academic spaces. And now we saw a really bad trend from 22 to 23. And so this shows that, I don't know what's going on. We're not doing so good with either recommending the vaccine, or parents are starting to feel more uncomfortable with the idea of getting their kids vaccinated. Again, we live in an era where TikTok, YouTube, and Google are educators. And so there's a lot of misinformation out there about this vaccine and about its efficacy and about its safety. And so we're seeing downward trends in Jersey. This graph here shows HPV up-to-date dose vaccination coverage among adolescent age by gender in New Jersey as well. So as you can see, this is a little bit more specific. So about the percent vaccinated, we were at our highest in 2022, and we're starting to see that downward trend again of, what is that, a 40 to 50% vaccination rate when it comes to HPV. I'm not sharing this to discourage anyone, right? We got to continue to do the work. We have to continue to promote. We have to continue to educate ourselves with new research that is coming out, but we also need to educate our patients, our parents, and even our kids, right, in school. It's very important to share that. And I actually want to take a minute to compare this to other vaccines, right? So if we're looking at, for example, the varicella and MMR vaccine, approximately 87.5 adolescents in Jersey, if the same age group, have received 2 or more of those. This is a little lower than the national average of 90%, but these are really good numbers, right? So almost 90% of our teens are vaccinated for varicella and MMR. Same thing goes for meningococcal. In 2023, the CDC reported that nationally, 88.4% of teens in the same age groups received 1 or more doses of the meningococcal ACWY vaccine, as compared to 93.8% in New Jersey. So nationally, we're doing better. In Jersey, we're doing better than nationally in terms of the meningococcal vaccine. And I'm comparing this to a couple of other vaccines, such as even Tdap, right? So Tdap also slightly higher in New Jersey, with a 90.3% vaccination rate versus the 89%. Yeah, the 89% in the country, right? So we're doing excellent. We're doing really good in terms of all the other vaccines. And why are we doing so well? Well, because these are mandated vaccines for school, right? So we're mandating Tdap, we're mandating meningococcal, but we are not mandating HPV. And it's, again, a conversation about our personal values. And obviously, we're assuming that kids aren't having any kind of sexual interaction, and it has nothing to do with school, right? And so we're not mandating this vaccine. But the scariest thing about it is that while it was at 63.7% in 2022, we are now at a rate of 50.2% in 2023. And these are the latest, this is the latest data that we have. And so we need to see how it looks for 2024 and 2025. But we're hoping to see an increase. But it was really drastic from the past couple of years. I believe in 2021, it was 54.5. 2022 was 59.7. So yes. Now, what are the reasons for low HPV vaccine rates, right? Apart from the fact that it's not a mandated vaccine in schools, it is also presented as an optional vaccine when offered with other age-recommended vaccines. So it may or may not be recommended by the provider, or the recommendation isn't strong. It's not recommended as important. It's recommended as optional, like, oh, okay, your child is going to get vaccinated today for Tdap and meningococcal, and you can vaccinate for HPV if you want to. And parents are like, no, I'm just going to get my kid the two that they need, and I'm done. I'll come back another day. It's not important, right? So it's seen as something that is not as important or as recommended strongly by the provider. Parents and providers view teens as not at risk due to them not being sexually active or thinking they are too young to be sexually active, as I mentioned prior. So as we know, though, the vaccine is best given before the adolescent onset of sexual activity, before there's any exposure. Parents have also their own reluctancy and hesitancy regarding the vaccine, and physicians may or may not be adequately prepared to answer questions or are hesitant to talk and engage in these conversations about the HPV vaccine, which prohibit them from being able to feel comfortable in recommending it. And it's maybe even they have their own personal values, which they say, I'm a physician, I'm a nurse, but I don't want to vaccinate my child. And now even if a parent was on the fence about vaccinating their child for HPV, now they're going to trust their trusted provider and pediatrician and say, no, you know what? If my provider isn't giving my child the vaccine, I'm not giving my child the vaccine. And that was a missed opportunity. And so the other is generally missed opportunities, right? So as a child gets older, the doctor's visits lessen due to the adolescent age. We go to the doctor every year with our kid. We make sure that they are, they do their annual checkups. And then once the kid becomes sort of middle school age, they tend to go less frequently, which is when the vaccine is given, usually. It's at 11 to 12. And last but not least, there is no system in place to know when a child is due for a vaccine, right? So parents will have their child's vaccine records and will understand, okay, I'm missing one more for MMR. I'm just going to make an appointment, or I'm just going to wait until the next annual visit to get my child vaccinated for this, and then we're good to go. But there is no system where that is statewide, that is mandated, where providers are required to call parents and say, your child is missing the HPV vaccine, and we're going to set an appointment. When are you available for? So this lack of system also diminishes the opportunities for HPV vaccine uptake. So what are some reasons that parents choose not to vaccinate, right? As I mentioned before, providers aren't really recommending it all of the time. And those who received recommendations from their child's healthcare provider was less hesitant than parents who received no recommendation from the provider, which happens a lot. They receive no recommendation at all. Growing number of parents are turning to social media / the internet for information regarding vaccines. And as I mentioned, a lot of misinformation on the internet regarding this one, HPV vaccine and HPV-related cancers. They believe, again, that their child is not sexually active, or they're like, I'm going to wait till my kid is an adult and they can make that decision for themselves. They see it as not needed or necessary. This reason is related to parents' perceived susceptibility to their children being exposed to HPV. And so and if there are parents, in my crowd today, maybe you probably had a thought or two about why you didn't think you should vaccinate. And these are all valid reasons, but if parents aren't educated or don't have the resources to be able to find their own, to do their own research or speak to a provider and ask their own questions, because sometimes you don't know what you don't know, right? You don't know to ask about HPV if you never heard of it, or if you have misinformation from your parents that said, oh, no, you didn't get that, and you shouldn't give it to your child. Or if, for example, there was a friend or a colleague or someone who said, once my child was vaccinated for HPV, they had, she got a horrible fever, or she had horrible symptoms. You shouldn't get your child vaccinated for that. So if there is a lot of personal connections that misinform about the vaccine, then parents are less likely to engage in receiving the vaccine or getting their child vaccinated for HPV. Again, we want to make sure that we are recommending the vaccine starting at ages 9. It is typically given from 11 to 12, but we want to start as early as 9. Studies have shown that initiating the HPV vaccine at age 9, they were more likely to be fully up to date by 13.5 compared to starting it at 11 to 12, when they are then fully completed by 14, 15, 16, where some kids are sexually active by this age. Again, older children or other adolescents have fewer doctor's visits. Therefore, initiating a series early provides more opportunities to complete the series on time. This will allow providers to give the 2 HPV vaccines at 12 months apart, as opposed to having the child come in for a third one if they started later. Again, so initiating earlier, there will be fewer vaccines needed to be given per visit. And sometimes when vaccines are bundled and provided as optional, the parent will only opt for the vaccines that are mandatory. So how to recommend the HPV vaccine if the child is already 11 through 13? We want to bundle them with the other adolescent vaccines to be given the same day. And this is really important in terms of the messaging on how we're doing it, right? So saying something such as, your child is due for 3 vaccines today that help protect against meningitis, HPV cancers, and whooping cough. I will be administering all 3 vaccines. What questions do you have? This messaging, as opposed to your child is going to be protected against meningitis and whooping cough, and if you'd like, we can give them the HPV vaccine. That changes the dynamic of the decision that the parent will make, right? So making it more of a, this is what is going to happen today, and then allowing the parents to ask their questions, or if they already have decided that they no longer want this vaccine for their child or they never wanted it, then they can provide their opposing opinions and say, no, I'm just going to do the 2. But if we message it that way as providers, then we are asserting that they will be protected from X, Y, and Z, including HPV. So I want to quickly show, this is about a 40-second video.
When I recommend the HPV vaccine to my parents and my patients, I always try to bundle it together with the other vaccines that they're getting that particular day. Usually they're coming in for an 11-year-old visit, and I'll go ahead and tell them that they're getting their meningococcal, HPV, and Tdap vaccine all in that same day. And the parents and the patients all they seem to respond really well when they know that it's just part of the 11-year-old series. And if they have any questions or concerns, I kind of approach each one independently, but usually they, again, when they know it's just kind of the recommended standard for an 11-year-old, they receive it really well.
So that was a little bit of an older video. Now in New Jersey, we are starting to recommend it, and across the country at as early as 9, which is what we want to continue to share. Recommend it as early as possible. So one study by Sean O'Leary found that the best predictor of vaccine uptake for both hesitant and non-hesitant parents was how conversations were started, right? And I touched a little bit on this. Motivational interviewing technique has been found to be an effective method for promoting vaccination among vaccine-hesitant parents. It is patient-centered, guided style of communication that empowers people to behavioral change by drawing out their own meaning in the behavior. You guide them to make the decision to vaccinate, right? So I want to share a little, go into this a little bit, right? So if you are providing a presumptive approach, saying that your child will get the 2 shots today, will get the 3 shots today, this is a declarative statement. This presupposes parents will get the shots. This normalizes vaccine decisions, and vaccination is a clear standard of care. This is the technique that we want to use, right? We want to declare that the child will receive these vaccines. In this case, parents resist 26% of the time. Using a participatory approach, asking the parent, what shot will your child get today, is open-ended and shifts the decision to the parent, right? At the end of the day, the parent will always have the decision over what's done with their child. They will always be able to say, no, I don't want this. I make the choice not to get my child vaccinated. But when we've used the participatory approach, parents resist 83% of the time. So we see that the way that we inform, the way that we ask our patients, or the way that we talk and deliver the message to the patients makes a huge difference. But the best way is actually motivational interviewing, because it shifts the decision while informing our patient of the choice that they're making the best possible decision for their child. So this, again, empowers people to behavioral change by drawing out their own meaning to the decision of getting their child vaccinated for HPV. This includes motivational interviewing skills, shortened, we know it as ORS. Some of you may be familiar with this, but the skills include using open-ended question, affirmations, reflections, and summary. So with the skill of using open-ended questions, it helps to understand the concern. The patient influences the direction of the conversation and avoids question and answer traps. So using examples such as, what are your concerns about the HPV vaccine? What would make you feel more comfortable about getting this vaccine if they did have any hesitations, right? Using affirmations validates the patient's concerns and acknowledges the person's strengths and efforts. So examples that the nurse or the doctor can say is, I can understand why that is concerning to you. And if you have the evidence and you have the information, you can share why that concern can be disputed, right? So I know that you're the type of person who likes to be informed and make decisions based on the facts. We're affirming what they know and we're educating on what they don't know. Reflections include careful listening and trying to understand what the person is saying. This can involve repeating, rephrasing, paraphrasing, and reflection of feeling. So mirroring what they're saying. What I hear you're saying is X, Y, and Z. From my understanding, you feel X, Y, and Z. And then ensuring through summary a shared understanding. This pulls together the different things that you've discussed and it can be used to transition. So let me summarize what we discussed so far. And that will allow them to feel as an active participant in their child's health care, but encourages the direction to flow in a way where the patient is now being informed and the patient is being validated. What are other strategies to increase HPV vaccination rates at clinics and offices? So again, very important, bundling the vaccine, motivational interviewing, and I personally, to me, this is the most important one, making sure that the message is that HPV vaccine is cancer prevention. Approach the vaccine as a tool to help protect against 6 different types of cancers and genital warts. Following with that is the consistent HPV messaging in a clinic, right? So that includes all office staff, including front desk staff, should receive training on how to communicate with parents and patients on HPV and be prepared to answer questions. The way an office staff communicates this information can influence a parent's decision to vaccinate their child against HPV. Why? Because if the doctor is doing an excellent job with recommendations and education, but they spoke to the front desk staff who said that they would never vaccinate their child for HPV, that gives them a very confused, but that's also another healthcare professional and they didn't get their child vaccinated. Or maybe the front desk staff shares that they've vaccinated, but the nurse that the patient is speaking to has the opposite opinion, and says, I'm a little hesitant. Like, I might get my child vaccinated for HPV, but I don't know yet. And that can increase hesitancy. So having a standard for the clinic about how to message the HPV material, how to educate, making sure that everyone is trained in the same manner, has the same information, can make a difference. Because as soon as a person comes in and the front desk staff is asking them, you're in today for 3 vaccines, right? And the parent says yes, and the front desk staff can say, I see that you're getting your child vaccinated for HPV, Tdap, and meningococcal. Great. I'll check you in. Sounds good. That kind of messaging can influence how secure the parent feels in their decision. Number 5, implementing a reminder recall process to check patients' immunization status at every visit. So if the vaccine was refused during the last visit, use the next visit as an opportunity to provide education on vaccine importance. And every other appointment after that is a wonderful opportunity to educate on different topics, including HPV. Sharing personal examples, if you have a personal example that illustrates the importance of the vaccine. So sharing personal example of your decision to vaccinate your family to provide cancer protection, and being prepared to answer parents' questions regarding the vaccine. The CDC has a great guide that can be reviewed to help answer commonly asked questions. The DOH does as well. These are all easily accessible on the internet. I was looking a lot at this document, which is the New Jersey Adolescent Immunization Data Brief, where you can see what New Jersey looks like in terms of vaccine uptake in Jersey. All of this information can be passed on to the patient, but can also help guide your knowledge and education, and also your messaging for parents. And they even have, which is lovely, they even have specific guided conversations and tools that providers can use to talk to their patients in regards to HPV and other vaccines. So yes, answering their questions efficiently. And I want to share from the Adolescent Immunization Data Brief what the DOH is recommending. So again, healthcare professionals should use strong recommendations when patients are due. Clinicians are the most trusted source of the vaccine information for parents and patients. A strong recommendation from a healthcare professional is the best predictor of whether a parent decides to vaccinate their child. And then healthcare providers should use evidence-based strategies to increase immunization rates. So things such as establishing a 16-year-old platform to help ensure adherence to receiving recommended vaccines at this age, as well as offering an opportunity for catching up on any missed vaccines. The DOH recommends providing educational material in waiting rooms. Materials should be in plain language and should meet the patient's social, cultural, and linguistic needs. And one thing that the Department of Health in Jersey does is that if you are a clinic, you can actually call them up and request materials that can be sent to your office, so that way you can provide it to your patients. Another recommendation is assess patient immunization records at every visit and provide education on the importance of vaccines, and plan to continue the conversation if a patient is hesitant, right? If a patient or parent doesn't feel comfortable we are not going to, if they already have made the decision and they're hesitant, they're like, no, I don't think so, not this time. We're not going to force and impose them. We can't, right? We're not under that legal obligation or that right to impose anything on our patients, but making sure that our messaging is, as we discussed, motivational interviewing, but also making sure that we are in the next visit bringing up the conversation again, talking about it at every opportunity. Using NJIS to conduct reminder recall reports to view patients who are due for vaccination or have missed vaccines, outreach to these patients to set up follow-up appointments. So this is an underutilized tool. For those of us who are familiar with reminder recall, we know that it increases patients' likelihood to go into the clinic to set up appointments. And so it's very useful. Recommending patients to download the Docket app and utilize it to provide proof of vaccination status as needed. So for those of us who aren't familiar with the Docket app, you can actually download it right now, and you can see all of your immunization records and your child's immunization records. And it helps. It has built-in reminders about when the patient is due for next immunization. So it's a great tool that can be used, and it's at your fingertips. Second to last, implementing standing orders to allow other members of the healthcare team to administer immunizations, right? So, for example, if at your clinic only the provider can provide the vaccine, opening it up so that your nurses can also provide the vaccine as well. And then considering hiring or working with a partner organization to provide community outreach and education to diverse populations, and being very, very culturally aware and using cultural humility when we're reaching out to patients, because we understand that we live in a very diverse country, state, and we see pockets of different cultures, and we need to be very aware, and we need to be aware and humble when it comes to the different people that we take care of and who we provide resources and support for. So to summarize, HPV is cancer prevention. The recommended ages are 9 to 26, but we can vaccinate up to 45. The New Jersey's HPV vaccine coverage rate is lower than Healthy People 2020 goal and Healthy People 2030 goal, and we want to work towards increasing this rate and providing strong recommendations that can be such as bundling with other adolescent vaccines if it's time for them to vaccinate. And so I like to share resources, but as I mentioned, the Center for Disease Control has educational. Sometimes I get ahead of myself and I share before I'm supposed to. I'm like, oh, wait, I did put that on a slide. But they have education for healthcare professionals. Also, the Immunization Act Coalition, which is immunize.org, has a lot of great resources as well. And also a list where we can sign up and we can receive the mailing from them, emails on a monthly or I think bi-monthly basis. The National HPV Roundtable and the New Jersey Department of Health will provide resources and has a lot of information online as well if we want to keep updated on HPV recommendations as well as any other childhood vaccine. That concludes my presentation. But yes, if anyone would like additional follow-up information, I will be at the front. Please feel free to ask questions. And for those who would like to connect, we can absolutely and certainly do so. But thank you so much.